Kalimera Sas, Roxana Mehran, President of the American College of Cardiology. Huge honor to be with you, to speak with you about optimal current and future pharmacological interventions in valvular heart disease. With 15 minutes, I'm going to focus only on the aortic valve, on aortic stenosis. Important for you to note my disclosures. Let's see, why are you not seeing my disclosures? Let's see that you have my disclosures specifically to my institution for the work that I do on clinical trials. So no question that there's been an incredible tsunami or a change in the way we're looking at valvular heart disease. First and foremost, the global trends, and in terms of the World Health Organization and understanding that the mortality is increasing in valvular heart disease, but we are now seeing many, many more patients have incredible opportunities. And the disparities in care continue to be quite high, especially with regard to access to TAVR and the best possible treatments available. And importantly, since I'm asked to talk about pharmacological treatments for valvular heart disease or aortic stenosis, it's important to understand that there is no medical therapy that can prevent yet or slow the progression of primary valvular heart disease. So I think there's an urgent need for us to better understand how to evaluate some of these non-invasive therapies and maybe even pharmacological. But what's relevant today is medical management when intervention is not indicated, as a bridge to intervention, but also importantly, when there is other things going on with regard to heart failure, atrial fibrillation, pulmonary congestion, and other things. But very, very importantly, and probably the node of this talk was with regard to how far have we come and what have we learned for antithrombotic regimens after valve intervention. But then, importantly, the control of blood pressure, prevention, treatment of prosthetic valve thrombosis, endocarditis, and of course, importantly, rhythm and rate management. But I want to talk about antithrombotic therapies, especially in valvular heart disease, especially with aortic valve, especially after TAVR, because the antiplatelet anticoagulant therapies now have been well evaluated. And in terms of comparing those and the underlying hypotheses of perhaps why would we even need anticoagulants, or when do we deploy antiplatelets, there are important valve-related and patient-related factors that draws us to these two areas of antithrombotic regimens. So with regard to antiplatelets, valve-related factors like stent endothelialization, since these, especially in TAVR, when there is a stent and a valve attached to it with the artificial surface exposure and tissue injury. And of course, these patients could have concomitant coronary and peripheral vascular disease, where antiplatelet therapies play an important role in reducing events and helping these patients. And anticoagulants, obviously, with regard to valve-related, there is the entity of valve leaflet thrombosis and flow turbulences, and also valve crimping that could be an important impact on whether or not patients should be given some level of anticoagulation. And then on the patient-related factors, these are the hypercoagulable states as well as atrial fibrillation. So let's see what data we have to support some of these hypotheses. First and foremost, antiplatelet treatment in patients that don't have any indication for anticoagulation has been studied in these 3 trials. And time again, we basically are seeing less is more, meaning single antiplatelet therapies being more importantly available. In terms of popular TAVI, the cohort A of those patients who had aspirin versus clopidogrel from aspirin, you see again, with regard to bleeding, less bleeding with aspirin monotherapy, and certainly no added benefit in adding clopidogrel. So again, less is more. But in those patients who require anticoagulants, we learned the hard lesson of giving rivaroxaban to these elderly patients at high risk does have an important risk of negative important implication compared to clopidogrel antiplatelet therapies. And of course, the Atlantis trial showing very similar with apixaban and very similar findings. None of these showed an important benefit in addition of an anticoagulant, and especially in comparison to dual antiplatelet therapies in reducing the risk of thrombotic events, except for showing perhaps some lower incidence of obstructive valve thrombosis with apixaban or edoxaban. And these are very, very interesting findings that I want you to keep paying attention to, because as we are seeing valve deterioration over time now, 7 years down or 8 years down the line compared to surgery, maybe we missed the boat in not figuring out what's the best anticoagulation strategy for these patients. And so this really does need to be evaluated. In terms of single antiplatelet therapy as the preferred antithrombotic strategy after TAVR, let's make sure that that is exactly what we are seeing in the large scale treatment of these patients with multitudes of trials, all small in number, but together showing us that perhaps less is more. In the anticoagulation strategies with indications, as I said, antithrombotic treatment in patients who have an indication for anticoagulation, we see that there's a lower risk of bleeding and non-procedural related bleeds with oral anticoagulants alone, without any difference in cardiovascular death. And that was shown in Popular, TAVI, and Atlantis. No differences in the primary endpoint. Then the same goes with Envisage with edoxaban. And what you might say, well, if I had to choose, would it be a VKA or a direct oral anticoagulant? Well, it's a no-brainer. Less risk of disabling stroke, higher risk of mortality with VKA compared to direct oral anticoagulants, and direct oral anticoagulants with less strokes and, of course, less bleeding. And so the guidelines are telling us exactly this. So the class 1A low-dose aspirin recommended for 12 months after TAVI, that comes with a class 1A. With 2A, class 1A for ESC guidelines, 2020 AHA guidelines, valve guidelines, and new valve guidelines are coming in that in patients that have no indication that single antiplatelet therapy is better. And I think you're seeing over and over that oral anticoagulants for TAVI who have other indications for oral anticoagulant, that's when it comes in to play. And I think it's important to understand that we also have data in terms of with Ocean TAVI that no antithrombotic therapy after TAVI could be also an option. So that's another interesting, no difference in net adverse clinical events when you have no antiplatelet therapies. And I think that's very, very interesting. So new is that there is the new could we have a new anticoagulant after TAVR? Well, there are some data in terms of non-antithrombotic therapies after transcatheter aortic valve intervention, and this is an interesting trial that's ongoing. And another one would be with ticagrelor monotherapy, or even just with ticagrelor plus aspirin, and those are under study. Beyond antithrombotic therapies, there are other pharmacological ways to handle this. SGLT2 inhibitors in aortic stenosis progression, very, very interesting data with the almost 12,000 patients. This was published in JACC Intervention, showing a tremendous importance in having these patients, especially for progression to severe aortic stenosis. DAPA in TAVI and aortic stenosis, also associated with less death or worsening heart failure, no difference in mortality. This is really, really important data. And I think RAS inhibition also very, very interestingly giving us some really interesting additional pharmacological treatments to perhaps think about cardiac damage and how we could use these in terms of improving outcomes for our patients. Sacubitril, valsartan in HFpEF with AF and functional MR. This is praise MR. I said I wouldn't talk about aortic valve, but this is just in mitral regurgitation. Imagining, no question that when you have functional MR, it's a good idea to have these patients on these drugs. Future treatments in Lp(a) and aortic stenosis is very, very interesting. This is a systematic review that shows this correlation of high Lp(a) associated with faster rates of progression of patients going into aortic stenosis. And I think this is something that we are looking at in the future. So the take-home messages, medical therapy in valvular heart disease is moving beyond symptom control and antithrombotic management, and a lot of very huge interest in disease-modifying strategies. After TAVR, less is more. Single antiplatelet therapy is the preferred antithrombotic regimens. Those who have an indication for an oral anticoagulation alone with a direct oral anticoagulant is safer and better than VKA. And then emerging data suggesting SGLT2 inhibitor, RAS inhibition, and heart failure-directed therapies. And then very interesting individualized future pharmacological therapies that might help us in ventricular remodeling, bleeding risk, and comorbidities. Those are all coming in with all of the detailed data that is coming and becoming available. I want to thank you for your attention. I'm sorry that I'm not with you, and I look forward to next visits in person in Athens. Thank you again, Onassis Hospital, and of course, Professor Iakovou and team.
Okay, so this was an amazing talk, as always. So a lot of information to decipher there. So of course, we know that we were discussing previously about the optimal dipletarid or anticoagulant therapy in these patients, and maybe Dr. Mariano can speculate on that. So maybe you think it's too early to get rid of the anticoagulant therapy in these patients. Of course, we are doing single antiplatelet therapy, but maybe it's too low, because how come we get to have HALT and valve thrombosis in the smaller valves in the 20 Sapiens and the 23 Evolutes, and not in the 29 and 34?
Yes, indeed. I mean, we do have data that show that we have less bleeding, of course, and less is more. It's definitely correct. But these data are like 1 or 2 year follow-up data. So I just ask myself, because we really don't know what actually happens with these valves that have this early degeneration, that have this leaflet thickening, this motion that's slow. We don't really know, and we cannot even see it in echo. So what I would suggest, because I do not think that we have the mid or the long-term data to know that the valves remain good with only aspirin, maybe it would be reasonable to consider doing a CT scan routinely after TAVR, with a protocol in order to see the leaflet motion, to see the leaflet thickening, and then decide individually if the patient is suitable for monotherapy aspirin or maybe not. That could be the
That's a good idea. And if we don't do that, we don't get to see the HALT, and yes, we missed a lot of HALT. And sometimes we do CT immediately or a couple of days after TAVI, and then we get to see hypoattenuation. So it's HALT in some cusps, and we give DOAC, and then it goes away.
Or so, maybe even more, just like 3 months and 12 months follow-up, always with CT, not only echo. And if something doesn't look good, then maybe 1 year, 2 year follow-up also with CT. I mean, that's could be a possible solution.
Okay, and Dr. Mariano has a comment.
I completely agree with the colleague, because we speak about Roxana is a mentor for me, and we speak about ticagrelor, aspirin, anticoagulation, but we need the data, objective data. So after we have to perform a protocol, complete tomography. For example, is a tailored strategy guided by data. So we have computer tomography, but we need the collaboration with the radiologists, the imagers, because I say this morning that TAVI is the first chapter. After we have to know about the consequences of our first procedure. So I completely agree.
Nice. Dr. Michalis, have a comment?
I think that we are moving to a very interesting era, and TAVI needs to preserve the valve as much as we can, and also we don't want all these patients to be overflown with the antithrombotic treatment because it does not help them. It's a very old patients, or majority of them they're old patients, and we need data to see how exactly we will manage all these pathologies, and also what exactly they mean, because some of them they don't mean a lot. You might see HALT, but what does HALT mean? Some of them they just go away without doing anything. Do we need drugs to everyone? Do we need to go up with a DOAC? And also when we see that HALT and all these CT scans, how easily do we recognize that that's something going on there? It's not always easy. All this, I'm trying to see all the scans myself. I don't know if the radiologists see more of what I can see. I doubt it, but I'm not so sure how exactly this can be diagnosed accurately.
I think we need to learn. We need to be more wise because we know sometimes alt thrombosis maybe is not prognostic, but we have to, as interventional cardiologists, we have to perform more, I don't know how to explain, more quantitative analysis of our procedure. Because sometimes I think that alt events depends on not good procedure. For example, predilatation, aggressive predilatation. As for stent, I think that computer tomography is useful for us to learn more about our comprehensive and strategy for our patient. Especially for a young patient.
Yeah.
This is my opinion.
Good.
We have to be more wise about this.
Thank you. So one final comment from Dr. Kalapas.
As we more valve-in-valve procedures going on, and we exponentially increase the antithrombotic management in this special patient population, it is of paramount importance. So, do you have any comment on that, Yannis, about valve-in-valve cases and the antithrombotic management there?
Valve is a milieu of thrombus, of thrombi, and valve degeneration. So we have a couple of strokes lately in valve procedures. And of course, we take the learnings from the big studies that filters don't do much, but maybe we need to incorporate them, at least in these cases. Still, the data is not there, but maybe these are the cases that we need to tackle adequately.
Yes, I think this is a more honest question. We don't know yet, and we do have to do what we do with normal TAVI, but I see it with skepsis, the whole thing, because we need more surveillance, like we talked before. Afterwards would be very important regarding also valve-in-valve patients, and good cooperation with the radiology department, and maybe aspects of inflammation to play also a role. We have to see of inflammation level if other factors do influence the whole process.
Good.
Just a small comment, because this idea about using CTA for TAVI is very, very important thing to use CTA for TAVI. But CTA is not for diagnostic purposes, to plan the intervention. So every single interventional cardiologist who performs TAVI has to learn how to do it himself. Cannot rely on what a radiologist tells him. Has to know it. has to learn CTA. And that's a very important thing. It's a different thing that you do CTs for diagnostic reasons, a different thing do CTs for planning and special intervention. The one who does the intervention has to do the planning and has to learn how to how to read the CTAs.
Maybe we say, because I think that some subset of the patient after the procedure,
we need more data, compute tomography, for example, as the same embolic protection. For example, in bicuspid, in small annuli, in, I don't know, a younger patient, I'd like to think that we need a check by computer tomography too after the procedure. Is crucial before the procedure. We agree with this. But in some subset of patients, maybe a protocol after the first procedure is important. And the computer tomography or fusion imaging for me is a mean.
And having said that, that's the idea, because now we're in a big sort of professional, if you like, sort of argument with radiologists who does CTs and who does the MRI. It seems that we come to a conclusion that we will be able to do MRIs, but it's a bit more difficult for CTs. And the idea how we will proceed with the European Society of Cardiologists, that will try to say that, especially when it's for planning, the cardiologists have to do it themselves.
yeah,
For the time being, we can't do it, even for planning, and we are not paid for that.
our chief 10 years ago, cardiologist and radiologist, is a skill that we have to manage. MRI is very important, very crucial for amyloidosis, for very exciting.
Maybe AI will give.
Possibly is a fight that is without any reason, because in a few years' time, there's no need for cardiologists, not radiologists, to do all these things. Artificial intelligence will do it for themselves, for them, and there's no reason for them to do anything. But AI has a problem that it creates de-skilling.
Yeah.
It's like the ones that when you do this square root, when I was a young student, everyone knew how to estimate square roots. Nowadays, you take this one, put there, you have the square root. Nobody knows how to do it manually. Forget it. The skilling is a big problem with AI, and we'll see that in the near future.
The skilling, even now you have the skilling in especially in our field, we have a lot of the skilled surgeons, and we will have a lot more at the end of the day. So in the previous session, we discussed with Dr. Pitsis about how many procedures you need to do to have in order to be a proper endoscopic surgeon. So it's 100 cases for each of one of the triad of valvular heart disease. So it's not easy to find in Greece. So I don't know about in Italy. And now we'll get to have lower threshold surgeons that maybe they will not be able to do a proper aortic stenosis, aortic replacement. And this is something that needs to be considered. And also, when we increase the number of places of cath labs that we have TAVI sessions incorporated in everyday practice. And for instance, in Greece, we have I presented today in the morning a slide that Greece has approximately the same number of TAVI centers as Poland, which is 4 times the number of cases and the number of patients, and we were double the number from Israel and Switzerland and Austria. So these are a lot of issues, and maybe you, as a president-elect of the Hellenic Society of Cardiology, it would be nice to give guidance and future directions.
Thank you very much. And I would